It's an aging lecture series, which is distinct. Reminding Jim from Galvin, Dr. Galvin is here as one of our external advisory committee visitors and will speak shortly. That we have a CNDR, Center for Neurological Disease and Alzheimer's Disease Center Grand Round. Dr. Tamori, you're welcome to join us from all of you who stay on. But we also have another lecture series that we're glad to host you for. And your lecture title is on the screen now, Detection of Cognitive Impairment in Multicultural Communities. And this obviously is very important. I want to learn as much as we can from you, because this is work that we need to do here as well. Let me just make three brief announcements that those who can know the award in aging research that we give out every year with Donald Shanghai, the Irma T. Herschel Professor of Pharmacology at Albert Einstein College of Medicine. And then there's the follow lecture, that's in November of this year, November 24th, December. The follow lecture is Fred Goldberg, I'm sure familiar to all of you. And in January, Dr. Tom Montini will lecture on January 8th. So Jim, as many of you know, some people greeted him from the audience. They remember him when he was a young lad in the lab, doing a fellowship with us. He's risen, of course, to prominence at NYU, where he's professor of neurology, psychiatry, nursing, nutrition, and population health. Do they all ask for a percentage of salary, or will you have to?
No one pays me anything.
No one pays me anything. And he's a director of a number of important entities at NYU, the Pearl V. Barlow Center for Memory Evaluation and Treatment, the Lewy Body Dementia Program. Work that Jim did here continues in this program, I'm assuming. The NYU Alzheimer's Disease Assistance Center is associate director of the NIA-funded Alzheimer's Disease Center, leading both the clinical and education course, which is a lot, it's a big challenge and a lot of work, and I know he's doing an amazing job. Let me just say he has over 120 publications covering basic clinical translation research, and leads a number of clinical trials investigating therapeutics for Alzheimer's disease, and has funding from many different sources, including Messenger Fox, NIH, Alzheimer's Drug Discovery Foundation. So Jim, it's really a pleasure to welcome you back again.
Well, thank you for the warm welcome, and I'm glad to see a number of people I have known for many years, although some I haven't seen for some time. I had more hair back then. So, as John mentioned, I'm involved in a lot of different projects, but I wanted to spend some time today talking about a project that's really kind of become near and dear to my heart, which is figuring out how to best assess the presence of cognitive impairment in multicultural communities, one, so we can provide better clinical care, but also so we get these individuals involved in research at the very earliest stage. And if people aren't aware there's a problem, it's very hard to recruit them to participate in a research project about that problem. So here's some of my disclosures. Most of the work I'm going to show you is funded by my R01s from NIH, and then also from the Shapiro Fund, which is a private foundation, and I have funding from other sources. I do work in a lot of clinical trials. None of this is relevant to this talk. And before I start, I thought I would just mention all the people who actually do all the work. So these are the people in my lab. Magda is my epidemiologist. Chaim is a neuroscientist. Arlene's actually a neuropathologist. Stephanie's an internal medicine doctor, and then the rest of my research staff, and then collaborators at multiple universities. All right. So what I thought I would do today, everybody hear me okay? I'm not a podium person, so, is first sort of discuss some of the principles of dementia screening, talk about potential benefits, talk about some of the barriers, talk about the relevance to public health, to sort of set the stage for the big picture. I wanted to briefly talk about the difference between the different types of screening instruments. An informant-based, where you're using an interview process, and a performance-based, where you're giving someone a task to do. I want to talk about some perceptions of dementia screening, some projects we've done looking at both what older adults think about dementia screening and what physicians think about dementia screening. And then talk about how we apply this in actually looking for detection of cognitive impairment in different communities. And I want to show you, demonstrate a couple of potential uses of these type of methods. So the diagnosis of all dementias really remains a clinical one. It's founded on a basic principle that there's intra-individual decline in their cognitive abilities that interferes with their ability to carry out their everyday activities. And so with that in mind, it's just important to think about how do we determine whether someone has changed from where they used to be. In this case, when we talk about the performance test, we'll talk about the challenge of using a performance-based test. Early detection probably is going to be very important. We want to be able to get people into clinical care as soon as possible, start therapies as soon as possible, but also to enroll them in research as soon as possible so that we can better understand the disease and potentially develop new therapeutics. So memory impairments are often one of the earliest signs of dementia, whether it's episodic memory or working memory. We won't debate that at this particular point, but the concept that people are somehow more forgetful and not able to do their task as well is really some of the earliest signs that people report. In research, we find some other tasks may change first, but in terms of what people report, that's what they typically say, is that mom's not remembering as well. Now, with formal neuropsych testing, that is having someone come in and talk with a neuropsychologist, is a very valuable tool, but that will never be confused with screening. It takes a long time to do that, and depending on where you're located, there may not be very many neuropsychologists. In New York City, you can't walk a corner without running into a psychologist. But when I practiced in Missouri, outside of St. Louis and Kansas City, you'd go miles upon miles without seeing any type of specialist at all. Matter of fact, in northeast Missouri, there was one neurologist serving 21 counties. So, there's definitely a disparity in terms of what specialties are available. So we really need sensitive and specific tools that are going to help us do that. So that's going to be the overall goal. If you think sort of about the natural history of any disease, in this case I'm talking about Alzheimer's disease, we can think about the biology of disease. So there's some initiation of biologic change, and then we can first detect some form of pathology. Then we have the signs and symptoms, which bring someone to medical attention, and then we finally get a diagnosis. And depending on how good our tests are, these stages can move farther apart or collapse closer together. But the idea is that at some point people are pre-symptomatic, and after a certain point they're symptomatic, and once they're diagnosed, they're clinical. And so these early biological changes, like for Alzheimer's disease, may begin 20 years or so before the disease manifests itself. And for all practical purposes, these are not detectable. But there is one way we potentially can find the earliest stages of pathology, and that's using a biomarker. So for Alzheimer's, it might be spinal fluid or amyloid imaging. But what we really want to do in the real world, because people aren't going to walk into a doctor's office and ask for get a biomarker, is how are we going to pick them up in routine practice? And that gets to the concept of screening. And the better the screening reflects the earlier pathology, the more likely we can collapse this interval. So Alzheimer's disease is a very common disease, the most common cause of dementia. Maybe 5.5 to 6 million Americans have Alzheimer's disease. Maybe another 2 to 3 million Americans have other forms of dementia. So a very common problem. What's interesting, though, there actually is quite a racial and gender disparity in the disease. So women tend to be affected more so with Alzheimer's disease than men. The Parkinsonian disorders affect men more than women. And there's a disparity in terms of racial and ethnic groups. So that if you look at the Caucasians versus African American and Hispanics, there's actually probably a higher prevalence of disease in non-Caucasian groups. And they tend to come to attention much later in the disease. So we really have less to offer them in general. And that probably has a lot to do with their access to health care.
Jim, is the greatest prevalence of dementia in women merely reflect their longer lifespan? I know this has been debated, and
so when you
more recently, people have gone back to the view that it's really equal to both. And just
so historically, it was thought it was due to their lifespan. When some studies are controlled for age, it's still seeing a slight disparity. So it's about 1.2 to 1.3 times greater risk. So about a 20 to 30-fold increased risk compared to men. And Parkinson's dementias are about a 30 to 40% increased risk in men compared to women.
And do those ethnic differences apply in Europe too? Do you see the same predominance of Hispanic over white and European?
Well, there are no Hispanic Europeans in general. general. So Spanish is Caucasian. Hispanic refers to New World people who were colonized by the Spaniards and learned the language of Spanish, but they are a different ethnic group. So there are no Hispanics generally in Europe, and relatively speaking, there are fewer African Americans in Europe than there are. So it's much more difficult. It's a much more homogeneous population there. It's possible, but I don't know that any studies have specifically looked at that. So I just mentioned that the U.S. population is becoming increasingly more diverse. So in 2008, 81% of older adults were Caucasian. By 2050, it'll be about 61. So you're looking, approximately a third to close approaching a half of all older adults are going to be non-Caucasian. And so we really need to consider what differences there are in how people perceive disease, how they access care, what they do with the care that they get, and how we're going to recruit them and retain them in research projects. I don't have time to go through all of these. These are kind of bullet points. But there are a number of cultural factors that are really important to come into play. There's the concept of what the knowledge is about the disease. There's the cultural belief revolving around the disease. How people have perceptions and expectations of the care that they get. What kind of structural obstacles there are. So in rural communities, again, as I mentioned when I practiced in Missouri, you have to drive a very, very long way to see a neurologist, so most people never saw a neurologist, even for a primary neurological disorder. So there's lack of access to care, the number of specialist transportation, so minority older adults tend to have to use more public transportation than private transportation, and so how accessible are they to getting back and forth using the public transportation systems. There are language barriers, and I'll show you an example of this in a little bit. There may be some differences in how the disease presents. So, for example, in African Americans, there's a higher incidence of vascular risk factors, and so their initial presentation of Alzheimer's disease might look different than you might see in a Caucasian older adult. There are a number of psychosocial aspects that play important roles. There are gender roles. There's the perceived role of the family in care. So, for example, in Hispanic families, it's typically the duty of the eldest daughter to assume the role of caregiver, even if there is still a spouse. This concept of familism or bellissimo. In African American communities, again, the children are expected to play a bigger role in caregiving, but there's not such a defined role. So many African American families who have larger families will have multiple children serving roles of caregiving, and they may or may not always agree with what's going on, and so there are a number of disparities that happen that way as well. And then there's some aspects of just the cultural approaches to research participation. So there's a large aspect of mistrust of the medical institutions, and that interferes or clouds the ability to get people into not only clinical care, but more importantly for research participation. So you're all probably aware of the Affordable Care Act, and so this was signed into law in 2010 and took effect in 2011. Like all legislation, it's big and voluminous, and most people can't read it, and if you could read it, you wouldn't understand a lot of it. But one of the things that's in there that's important is the concept of adding an annual wellness visit into the benefits for Medicare beneficiaries. And this annual wellness visit actually has something called a personalized prevention plan. And so this personalized prevention plan gets to get this idea of risk assessment and then a plan to try to prevent diseases from occurring. Why is this important? Is because almost everybody goes to their primary care doctor for most of their medical care. Relatively few people go to specialists as the initial contact. So about 83% of people who have Alzheimer-related problems first go to their primary care doctor, not to a specialist. So this is actually the elements of the prevention plan. What's interesting is you ask most primary care doctors, they don't necessarily know that there is a personalized prevention plan or what they're supposed to be doing to bill for that annual wellness visit. So it's supposed to have medical and family history, their medications, height, weight, and BMI, their blood pressure, and then what I highlight here actually in the legislation is that they're supposed to be doing the detection of cognitive impairment and then an establishment of a written screening schedule for the next 5 to 10 years. And I can assure you that that's generally not happening across most medical practices. The other challenge is that, like all legislation, they say to do this, but they don't give you any guidelines about how to do this. So you could do a cognitive test that could count as screening, or I could just say, hey, how's your memory? Oh, it's fine, and that might count. You could check off that you screened. And obviously that's not going to be a very effective way of doing it. So the Center for Medicare and Medicaid Services,
You can't bill for it, so there should be that incentive.
there's a billable code, there's a G code for the annual wellness visit, the initial visit, and the follow-up visits.
Do you think that will change the practice by GPs to incentivize them to?
We'll talk about that. I think the reason is that there's no clear way in how to do this. So CMS, or the Center for Medicare and Medicaid Services, actually has definitions to guide the legislation that's derived from the legislation. So they define cognitive impairment and functional ability, and I won't read the definitions, but there are definitions that are used in order for quality and control and for auditing of services that are billed. And so I just want to mention for the impairment, you can assess the persons by direct observation, by an informant, or by performing a test. So there's a couple different ways that you can do this. The other thing I just want to briefly mention is that older adults tend to have lots of comorbid diseases. It's called multiple chronic conditions, or MCCs is the CMS term for comorbid diseases. And so this is just looking at Medicare beneficiaries nationwide and just in New York City. And you can just see that Alzheimer's disease is about as common as depression, about 1/3 as common as diabetes and heart disease, is more common than asthma or COPD, and most people have multiple conditions. Why is that important? Because if you look at the actual cost of caring for these individuals, if you look at people with coronary heart disease, diabetes, or COPD, in the red is the cost for people without Alzheimer's disease. In the blue is the cost of people with that disease plus Alzheimer's disease. So Alzheimer's disease acts as a multiplier, about a doubling of the cost of caring for older adults. Most of it due to the fact that because of their cognitive impairment, they're not very good at taking care of their other medical conditions. And since most people are not diagnosed until later in the course of the disease, you can see how this could really drive healthcare costs up. There's also strong associations between someone's cognitive status and their activities of daily living. So if you look at the ADL limitations by cognitive performance, as people become more impaired, obviously they have more impairment in their ability to do their everyday activities, both their instrumental and their basic ADLs. So there's a clear relationship between all of these chronic multiple medical conditions, between Alzheimer's disease, between the cost and the lack of the ability to readily detect these diseases at the earliest possible stages. So what I'm going to do for the talk is every now and then I'll just kind of summarize where we are at this point rather than waiting until the end. Alzheimer's frequently coexists with multiple chronic conditions. It adds to the cost, it worsens the outcomes. Healthcare reform suggests that we should be screening for these things, but doesn't give any guidance as to how to do it. And if you don't know how to do it, then you probably don't do it quite as effectively as you would otherwise. Now, there are lots of brief tests out there. This is just a couple of them. There's lots of them because not any one is optimal, and they each have their limitations. So if you use a brief performance test, that is have someone in front of you and you give them sort of a pencil and paper test to do, they may be insensitive to the earliest stages of dementia. They may have some cultural bias to them. They may be weighted toward one domain, lacking another domain. For example, the memory impairment screen only tests memory, nothing else. It's 4 words, immediate, intermediate, and delayed recall. So if you have a non-Alzheimer's dementia, the MIS is not going to pick it up because non-Alzheimer's dementias have fairly good episodic memory abilities early on. The other thing is you have to compare these tests to some normative value. Okay? Now think about this. If I've never seen you before and I'm meeting you for the very first time and you're 85 and I'm going to do a mini mental state exam and I give you the test and you score 25, what does that tell me? It simply tells me you scored 25. I don't know how you would have done before. I don't know if that represents a change. And I don't know if that 25 interferes with your ability to do your everyday activities. And remember, the definition of dementia is a decline in abilities that interferes with your everyday activities. So a test by itself makes it very difficult to determine whether there's actually a problem. So you can, again, you can do more formal neuropsych testing, but that's not readily available in those situations. Now, there's a tool called the Clinical Dementia Rating Scale. So it's a global dementia rating. It was developed at Washington University. And so it stages the presence and severity of dementia. It's quite reliable and valid. It has great psychometric properties. It does very well as a gold standard for clinical trials and for many longitudinal research projects. But it's a long process. So depending on who's doing the interview, it can take up to 2 hours. Okay? So when I do it, it's about 45 minutes. And some of my psychiatrist colleagues do it, it's 2 hours. Right? Because they're asking lots of hypotheticals, as psychiatrists sometimes do. So for all practical purposes, it's not something you can do in routine clinical practice. Not readily available. However, it uses this concept of getting an informant. Okay? So asking someone who knows the patient really well whether the patient has changed, and does that change interfere? So a consistent report can give you a sense, is there a problem? So instead of comparing Mr. Jones to some normative value, or comparing Mr. Jones to Mr. Smith, I want to compare Mr. Jones now to how Mr. Jones used to be, and who better to tell me than Mrs. Jones? Okay. And so these type of assessments, each person serves as their own control. So it tends to be less biased by socioeconomic status, language, culture, race, education, etc. And so if you have a brief scale that you want to get readily uptake into the community, it has to have some attributes. So it has to be predictive of early dementia. We don't need tools that can tell normals from nursing home patients. You can look at that and see that. We need a tool that's going to tell a normal from a very mildly impaired individual. It has to be inexpensive. It has to have high face validity. That is, a clinician sitting in his office looking at this tool and say, yeah, I would use this tool. It makes sense to me. It has to be reliable. It has to be sensitive and specific. It has to be brief. Because the average office visit for a primary care doctor in the United States, anybody know? 5 minutes. 5 minutes if it's a male doctor and 7 minutes if it's a female doctor. And the patient has approximately 25 seconds to state their chief complaint before the doctor intervenes. Okay? Where did I get that from? Men's Health. Men's Health, great resource of information. They polled 30,000 people, and so it's probably a fairly accurate number. Has to be easy to administer and score, has to be socially acceptable and culturally sensitive. If it's not all those things, people just aren't going to use it. So one of the things that, a project that I led when I was still at WashU was we created a tool called the AD8. AD doesn't stand for anything, it just was a catchy title, AD8. If you want, it could be ascertaining dementia, but it doesn't really mean Alzheimer's disease. And so these are 8 questions, they're scored yes, no. So yes, there's a change, or no, there's no change, and you add up the number of yeses. Okay? And so problems with judgment, reduced interest in hobbies or activities, repeats themselves, trouble using appliances, trouble with the month or year, trouble doing finances, appointments, and are these problems occurring daily? Okay? Now again, you're trying to capture, is there a change? First, my grandmother's 93 years old. She's sharp as a tack. She repeats herself. She's always repeated herself. Since I was a little kid, she would tell you something, 2 minutes later she'd tell you the same thing, another couple minutes later she'd tell you the same thing. So for her, that's not a change. So we don't count that. We're looking for someone who didn't used to repeat themselves, who now is repeating themselves. And so if you start to look at some of the properties of this, so the CDR, just so you know if you're not familiar with this, 0 is not demented, 0.5 is very mildly impaired, 1, 2, and 3 is mild, moderate, and severely impaired. And you can see that people who are CDR 0, their informant rates them at less than 1. But people who have even the mildest impairment, their informants rate them almost 3. So we have a very natural sort of cut point around 2 that gives us good discrimination between groups. And so these are the receiver operator characteristic curves, or ROC curves, gives us discrimination. The bigger the area under the curve, the more powerful the tool is. So in our first research sample, or development sample, to discriminate non-demented from any demented, it was over 90% discrimination. And from CDR 0 versus 0.5, which is sort of the mild cognitive impairment stage, it was about 83%. And that was in that first pass research sample. We then went and validated in a clinical sample, so in real-world clinical practice. And so we demonstrated all the different psychometric properties. And if you know something about instrument development, there's validity and reliability, and they are quite different. And you really need to establish both, and there are multiple forms of each. So you want to see how well it does against the gold standard, how well the individual questions correspond to the gold standards. Is it free from random error? Is there intra-rater reliability? So if I do it now and do it later, do I get the same score? Inter-rater reliability, that if two different people rate, do they give the same score? Intermodal reliability, so if I do it in person or over the phone, does it perform equally well? And how well it discriminates. So suffice it to say, without going through all this, it does really well. And so in real-world practice, we're able to discriminate about 92% of individuals. And it works well regardless of the cause of dementia, Alzheimer's, vascular, Lewy body, frontotemporal, etc. It doesn't matter what your characteristics are. So that works equally well by age, by gender, by race, by the type of informant that we get, by your mini-mental scores, or by your CDR. So it performs really quite well. This takes about 2 minutes to do, so very, very brief, easy to fill out. When we published this, one of the reviewers came back and said, well, that's great, but what happens if there's not an informant around? Could the patient rate themselves? And I'm like, well, I don't think so, but why don't we test it? So we actually did it as a self-administered tool. And what we found was that people who were not demented rated themselves about 1, which is the same as what their informants were rating them. And people who had even the mildest of impairment were rating themselves about 3, which is what the informants were rating them. So we did a really good job of discriminating. What you'll see here, if you look at the pattern closely, though, as people become more demented, the informants rate more symptoms, but the person doesn't. So individuals can pick up impairment, but they can't rate the severity of their impairment. Okay? So this is important because there's this concept called anosognosia, which means people are unable to recognize their cognitive deficit. And that's not true. They recognize there's a problem, they just can't rate the severity and frequency of the problem, but they can tell you that things have changed. And so one other way to look at this is something called effect size. And so the idea is that you want to see how well the two groups can be discriminated. The bigger the effect, the more powerful the tool. Okay? And so from the informant version, the effect size is 166%. So it's a very large effect, very easy to discriminate impaired from non-impaired. But even from the participant's perspective, it's almost 100%. So very large effect size. Now, I'm not discounting using a pencil and paper test. It's valuable to see how people perform. But I talked about the limitations of that. What happens if we combine an informant interview with a brief performance test? Can we improve our ability to pick up disease? And in fact, we can. So if we combine the 88 plus like a wordless recall kind of task, we now discriminate about 97% of individuals against the gold standard. And for MCI, about 91%. So very powerful tools doing very, very brief tests, just tapping into different aspects of cognitive impairment. The other thing we wanted to demonstrate is whether these changes in these tasks correspond to biomarkers, right? In other words, if we have a test that says someone likely has Alzheimer's disease, do they in fact actually have Alzheimer's disease? And so we looked at both amyloid imaging and CSF biomarkers. And what we found was if your 88 score was less than 2, your biomarkers were all in the normal range. And if you had an 88 score of 2 or greater, they were all in the Alzheimer range. And these were highly statistically significant differences. Okay? So people who with 88 scores of 3 have high CSF tau and phospho-tau, low CSF-A beta, and they had amyloid depositions by PET scans. And so the 88, this little 8-item questionnaire, performs as well as the full CDR, right? So we go from 2 hours to 2 minutes and perform equally well in terms of discriminating individuals. The mini-mental state does okay, but when you eliminate anything past the very mild cases, then the mini-mental state no longer does a good job. So the mini-mental state is not good at discriminating very mild disease. So one of the ways I'll just show you how that works is we did something called a sensitivity analysis. So we looked at the 88 and mini-mental scores across multiple things. So gold standard ratings of whether they were demented or not, their logical memory test on their neuropsych testing, which is an episodic memory test, their PIB binding or their amyloid binding on PET scans, and their CSF beta. And so if we use the traditional cutoffs for both tests, that's the red line, the 88, we only have 5 false negatives. That means we only missed 5 people who were actually impaired with the screening. To use the mini-mental state exam, we missed 74 people within the same sample. Okay? So that's a whole lot of people who were impaired that we call normal, which means they're going to have a delayed diagnosis and a delayed intervention. So with that as an aspect, let's get down to the rest of the talk, which is sort of addressing multicultural communities. So we developed this test in Missouri, that's where we did it. And Missouri really only has whites and blacks. There are almost no other ethnic groups in Missouri, right? So 86% is white, 13% is black, and then everybody else makes up that 3% difference, okay? So it's not really multicultural in that sense. But as we developed it and showed its properties, there was a lot of interest, well, would this work in other places? And so I had the opportunity now to collaborate with investigators around the world. And so we've done studies in Canada, both French Canada and English Canada, across South America, across Europe, and across Asia. Translating the test into their native tongue and doing the study. So this is in Ecuador, where the average educational level is about 5th grade education for most people living in the communities. So we translated into Spanish and we did a study. This was published last year. And what we found was, compared to a gold standard, we had excellent area under the curve, and we had the same cutoff, the cutoff of 2. So in Spanish and English, the same cutoff. We did this in Korea. And so area under the curve is about 88%, and the cutoff is 2. Same psychometric properties. So this is in French, this is in Portuguese, Chinese, in Tagalog, which is Philippines, in Norway, and all those other countries that I was mentioning. So it works quite well regardless of the type. But let's get to this idea of being sensitive. So Spanish is not really a monolingual tongue. There are lots of dialects. And so I just want to show you the difference. So this is the first question of the 88 problems with judgment. And these are 5 different Spanish versions from Spain, Colombia, Ecuador, Argentina, and Chile. And even if you can't read Spanish, you can see that those are not the same questions. Okay? Yet back translation, they all perfectly match English. But forward translation into dialects of Spanish, you get quite different questions. And so if you had a version of Spain and you tested it in Chile, you might not have the best matching criteria because the dialect's different. Okay? And so whenever you're translating something, you also have to translate into the correct dialect. So that's what's really being culturally and linguistically sensitive. All right. So what do we learn from this part? Well, dementia screening can be done either by an informant process, an interview, or by a performance test. And to be effective, this instrument has to be readily generalizable and translatable into any community. Right? If it only works in one group, it's never going to have much uptake. Right? It has to be able to work across groups equally well, regardless of what the patient's characteristics are. So the 88, and I have a lot of underlines here, just to give you a sense from that list I showed you before, remember those attributes, is brief, valid, reliable, sensitive, predictive, and discriminating, all causes of dementia, inexpensive, in a culturally and linguistically sensitive fashion, socially acceptable, and is biologically validated against biomarkers. So it makes it an ideal test to use actually in studies. So now, dementia screening means that now these are not people coming to clinic. These are people you're going to go out and screen, just like you can screen blood pressure by setting up a kiosk at a supermarket, and people will stick their arm out and measure their blood pressure and try to find people who likely have high blood pressure. Okay? So screening means you're now doing unselected samples. And so it's important before you do a screening program to figure out what people actually think about that. And do they want to actually be screened? So considering that older adults are at the greater risk for screening older adults seems like a natural target. So we need to be able to identify what barriers there are and what perceived benefits there are for people to do this. And this is the way we can develop national screening programs. This is true for breast cancer awareness, this is true for high blood pressure, it's true for diabetes. You have to figure out what people want and how they think about it and what they're going to do with the information. So what we did was a large population-based survey. We used some conceptual models, and this was our conceptual model. For people who were not familiar with behavioral sciences, measuring behavior is great, but in most cases, most people have not done the behavior you want to measure, so you can't measure that. You have to measure a proxy for that. And the theory of reasoned action suggests that the best proxy for a behavior is the intention to do the behavior, which explains about 40% of the variance of the actual behavior. Okay? So we can use the intention to undergo cognitive screening and ask people questions about that. And so we used some valid psychosocial constructs to develop a model and a questionnaire. And so what we did was a random digit dialing study. So we called random people in the community and asked them to answer a questionnaire. So the way you do it is you generate numbers from a computer. You try to see how many numbers are actually valid, real phone numbers. So we attempted 14,000 phone calls. 10,000 actually hit a private residence. 7,000 we actually made contact with a living person. 1,800 agreed to be interviewed, but then some of them got excluded because of the exclusion criteria. So we did 1,039 interviews. Okay? This was a 169 questionnaire, took 40 minutes to do. Okay? So your callers have to be really good at keeping people on the phone, and they got a $10 certificate to do this. So we had an 82% responder rate and a 72% completer rate. So very good prospects for looking at whether the survey was valid. And so these are the sample characteristics. And so we had a rural population, Adair County, a suburban population, which is St. Louis County, and an urban population, which is St. Louis City. And so those are the characteristics. The reason I'm showing you this is when you do it right, this is the state of Missouri. Our survey exactly matched the state as a whole, right? So when you're doing random digit dialing, if it's done right, it really gives you a true sense of the population. Okay? And so what we're able to use is structural equation modeling to actually develop a model to understand people's intention to screen. And so these are the 5 domains that were the predictors. So did they know something about Alzheimer's disease and its consequence? Did they perceive a benefit to getting screened? Did they have other preventive behaviors, other screening behaviors that they were already doing? Did they have self-efficacy or the confidence to carry out the behavior? And did they perceive themselves to be susceptible to the disease? Okay? So with these, you can actually start to think about how you can develop an intervention that can target people to increase their awareness and discuss the benefits of this and tie it into their other health behaviors. Okay? So that you can move it from being just like, oh, I don't want to talk about my memory, so let's talk about our health. There are also some significant cultural differences. So we looked at, remember in Missouri, people are largely either African American or Caucasian, so we can only compare those 2 groups. And what we saw, for example, African Americans are much less likely to use the internet to find health information. They were much more dependent on public transportation than their Caucasian counterparts. They had poorer health ratings, higher perceived barriers, lower perceived severity, less knowledge, and a lower perceived accessibility to memory care. So there's a whole bunch of barriers out there that they perceive. Now, whether they were real barriers or not is irrelevant. This is what you think, then this is how your behavior is guided. So you can see that they had much higher perceived barriers and a much lower perceived severity. So that is that they didn't think the disease was really going to cause much of a problem, and they just saw a whole bunch of problems with getting screened. So if you don't think it's going to affect you very much, and you see a whole bunch of barriers to screening, guess what? You're not going to participate in these things. So we did some logistic regressions, and we found that the intention to screen was predicted by being white, male, having some anxiety about the whole process, having self-efficacy, having knowledge that we can do this, and that you have some social support, some support mechanisms. So again, it gives us some idea of developing an intervention. So what we have now is we have the basis for developing a dementia screening program, right? We have to clarify what dementia is and what the consequence of the disease is. We have to discuss the benefits. We have to give them confidence to talk to their physicians about this. and we have to translate this into their overall health rather than just keeping it as a separate topic. Okay? So this allows us then to develop some tailored approaches to different groups, knowing what some differences are. So that was from the patient perspective. What about from the physician perspective? So we did another survey of physicians, the same thing, and we tried to find out what they thought about screening and how they communicate with their patients. So we interviewed 200 primary care providers. Physicians felt they were much more likely to find well-established disease than detect new cases. They didn't feel very confident about that. That's consistent with the fact that in the United States, moderate stage Alzheimer's is the most commonly diagnosed stage. The physician beliefs really guided their evaluations. While the majority of people would evaluate the patient if the patient complained, only 25% of physicians thought it was their job to actually check for cognitive problems. Okay? Nearly half believed that it was not part of their practice, and 10% didn't use any type of tool whatsoever. So their entire assessment was just asking someone how they thought their memory was. Okay? That was the entire assessment they did. Okay? And it was interesting, the respondents, and I'll show you, were actually very active in other screening modalities. This would suggest that if you could somehow tie some guidelines together to give them structured instructions of how to do it, they would probably do it, just like they do screening for breast cancer or prostate cancer, or screening for diabetes with hemoglobin A1C. So when we modeled this, we found some really interesting things. And again, I'm not going to read the whole thing, but suffice to say, there are two ways that we modeled it. So one is, was it a consumer-driven practice? That is, the patient walked into the office and complained about something. So think about this. If you see your doctor, he doesn't ask you about your back unless you've complained about your back. But once you complain about your back, then he always asks you how your back is doing, right? So that's a consumer-driven approach. A guideline-driven approach is, you're 45 years old, it's time to get your first colonoscopy, right? So the idea is that regardless of whether you complain or not, there's a guideline that drives you to do it. And the behaviors are quite different depending on what the practice is. So if it's a consumer-driven practice, it's really predicated by a subjective norm. That is, what that physician being told his other physician colleagues want him to do. The biggest predictor. And if it's a guideline-driven practice, there has to be some perceived benefit of screening, right? So if I do a colonoscopy and find an early polyp, I can remove the polyp and reduce the risk of getting colon cancer. Well, if I'm going to screen for dementia and detect early dementia, there has to be a benefit to the patient to doing that, right? So subjective norms are somewhat easier to address in some way because that's a cultural change, right? By raising awareness about the disease and what to do about it. Perceived benefits are going to require therapeutics. Therapeutics require people to participate in research, and that's getting to the basis of why we need to find out what people know about the disease and how to get them into a project. So what we learned really was that there were very, very big differences in behaviors among physicians, but the physicians, by and large, who were most likely to screen patients were younger, they were less experienced, they were much more likely to be female and non-Caucasian providers, and most of them were family medicine. So the family medicine group was much more willing than the internal medicine group to do these types of things. So let's move forward to the present time. And so my RO1 is to do this out in the community. So now that we understand what people know about the disease, we know how to communicate with their physicians, we know how their physicians look about screening, we have valid tests. Can we actually just go out and do broad screening in the community and find disease? Okay. So this is a community-based assessment. We go out into the community. It's not done in our center. We just go out and we, churches, community centers, book clubs, wherever. And so we collect demographics, financial resources, preferences. We do cognitive and behavioral screening. We also do medical screening. So we put it in the context of healthy body, healthy mind. And so we link the cognitive screening to blood pressure, diabetes, and COPD screening. We also do anthropometric measurements. We use impedance to look at body composition. And we have a follow-up with a social worker 2 months after the screening event. Many of these people come and do gold standards because they want to validate what we find in the community. So they come to the ABC and have an evaluation. They also have MRIs, PETs, EEGs, blood, and spinal fluid. So we have a rich data set right now. We have over 500,000 individual data points. I just got an administrative supplement to my R01 to bring the libraries to actually make a data dictionary and an anonymized data set because we have too much data. We actually have no way how to handle it at the moment. It's all sitting in a SAS database, but it's very difficult to utilize because there's so many data points. So how do we do this? Well, we carry a little Pullman with us to the event. Each coordinator has a Pullman along with them, and they have equipment. So they have a body composition, which is a scale. You pull these little handles out, and you hold it. You stand barefoot on the metal, and you hold it in your bare hand, and we get body composition. We have a dynamometer to loop the grip strength, and we have a tape measure. And then here's the paper tools that we use. We have the mini physical performance test, which is a frailty and falls risk evaluation. We do the MOCA, which is a brief cognitive test. We do the 88, which is the informant interview, but we ask the patient themselves, so it's a self-report interview. And we also do the mini-cog, which is another brief cognitive test. And so what we've really been able to find is some really interesting things. So first, let's look at health out of the community. And so if we use the Caucasians as a reference group here, all the red is the group that's different than the Caucasians. So you can see there's difference in terms of their health and their strength and their body composition. So there's quite differences in people's overall health out in the community. And I'll show you an example of how we use that information going forward. But we've also been able to look at some associations between all these different measurements and the screening tools. So, for example, the 88 is much more closely linked to comorbid diseases and mood disorders. The MOCA is more linked to some anthropometric differences. So different tools are going to be associated with different aspects, and we can think about how we can model that going forward. We've also been able to look at predictors of cognitive impairment based on these characteristics, either their demographics or their health-related aspects. And so again, so comorbidities link really well with the 88, and anthropometrics link much better with the performance type tasks. So let me just give you an example. So if you want to look at risk factors for cognitive impairment, let's look at some medical risk factors. So one that's been linked in the literature is something called sarcopenia. So sarcopenia is the loss of muscle mass and strength with age. So we have people who have no sarcopenia, that is, they have normal muscle mass and normal strength. We have people who we call pre-sarcopenia, so they have low muscle mass but still good strength. And then people who have sarcopenia, they have both. And so we looked at whether they were going to have a cognitive impairment or a physical impairment. And what we found was that people who have sarcopenia are at a much higher risk of being quite impaired. Okay? So sarcopenia is a very easy sort of medical way of screening for potential cognitive impairment. And so physicians who don't want to do cognitive testing are much more willing to do medical measurements. And if you can identify someone who's developing weakness and loss of muscle mass, they're at a very high risk, not only for falling down, but for being cognitively impaired.
Is sarcopenia the same thing as frailty?
No, frailty is a syndrome that encompasses both subjective complaints as well as objective findings. So sarcopenia is a component of frailty, but complaints of weakness or fatigue are the subjective parts of frailty. So frailty has both objective and subjective components. But subjective things are so hard to measure, objective things are easy to measure, and this is a very strong objective measurement, very easy to do. The other thing is I want to show you just some differences here. So we do body composition, and so if you look at overall body fat, what you see is a very strong relationship between physical performance and body fat, but not a very strong performance linked to cognitive performance. But if you look at visceral fat, that is the fat around the organs, right, which you can measure by impedance, you get a very strong relationship to cognitive impairment, but not a very strong relationship to physical impairment. So as people become more fat, they have worse physical performance. But as they develop more belly fat, they actually have worse cognitive performance. So there are distinct differences in how you're starting to look at the older adult, right? So the older adult that just has a big BMI, is big all over, physically may be impaired, but cognitively may actually be intact. But the older adult that comes in with a big belly, right, is much more likely to have cognitive impairment. Now, you're not always going to have an impedance machine, so so that's not practical in most cases. But what you can do is with that tape measure the hips and the abdomen. And the abdominal to hip ratio is even stronger relationship to cognitive impairment. So the bigger your belly is compared to your hips, the more likely you are to have a cognitive impairment. So again, a very easy way of looking at mental health and mental health together and trying to improve detection in the community. The last thing I want to just mention is what about some behavioral changes? So what we do is we call them back 60 days after the assessment to see what they did with the information. So one thing we found out, about 40% of people were utterly surprised by their results. No one had ever told them they had diabetes. No one ever told them they had high blood pressure. No one ever told them they had a cognitive impairment. So they were really quite surprised. 90% of people found it quite useful for their future medical planning. Only 55%, however, shared the information with their families, and only 38% shared it with their providers. Right? So this gets to this perceived accessibility, right? So we give them this information with all this wealth of information, resources, and referrals, and they're not acting on it. Okay? So in order to make this really successful, we have to figure out how to facilitate entry into the healthcare system. Screening by itself will fail. Screening with facilitation will succeed. So let me just give you a practical example. So I worked with the Administration on Aging, and so what I did was I trained all of the field workers in the 10 AAA agencies in Missouri to do dementia screening. So I did a 2-day training session with the AAA workers. So they went out, and AAA workers, what they do is they go out into the community and they do home assessments of older adults. They do assessments of everybody, but we're going to talk about the older adults. And so they did dementia screening as part of their assessment. So we screened about 4,000 people, and we picked up an incident rate of 28% of cognitive impairment. So a fairly high incident rate of cognitive impairment out in the community. Previously on incident cases, not prevalent cases. Okay?
People over 50 and people over 60.
Geriatrics over 65.
Over 65.
Okay. And then those people who we identified, we tried to refer for an intervention. Okay? So through the process, 244 got referred to an intervention. The intervention was this care consultation, which basically was a way of facilitating their entry into social and medical services. Okay? And we compared these to usual care controls, and we found that we improved mood, we improved knowledge, we improved social support. That's all well and good. Really importantly, we actually delayed entrance into nursing homes. Okay? So there was a 3-fold reduction in transitions in care from independent living to skilled living by early detection and facilitated entry into social and medical services.
Was this an Administration on Aging grant?
Yes.
That
It was an AOA grant to the state of Missouri, and then they administered through the AAAs, the 4 chapters of the Alzheimer's Association to me. Yeah.
Were these already people that were identified to the AAA system already, identified with some degree of need for help?
These were all initial assessments. So people get to the AAAs for a lot of different reasons. So there are multiple reasons why they get there. They tend to be underserved communities more than anything else. Last thing I just want to show you is just a cool picture, because this is like hot off the press, and we haven't written it up yet, but I just want to show you what we're doing with some of this stuff. So many of these people have gold standard evaluations. They come to the ABC, they have MRIs, they have PETs. We're just starting to do LPs. This is the fluid I'm going to be sending to Les to analyze. And we've done free surfer analysis, and we can find links between MoCA performance and hippocampal volumes, ADAs and cortical volumes. But this is kind of really cool. So we are able to do a lot of structure-function relationships to behaviors. And so this is stuff that's kind of off the press. I'm only going to focus on one for lack of time. So I want you to focus just on this part. So we do fMRI, and we use a network analysis. We don't do seed-based approaches. So seed-based approaches, you drop the seed, you see what lights up. We do network-based analysis. So we have a 256 ROI network that we do that really covers almost all the different networks of the brain. So from here to here, here's attention, subcortical, salience, frontoparietal, visual, default mode network, auditory. Here's the cinguloopercular network, and here's the sensor network. So I'm going to take the cinguloopercular network out and show it right here. Okay? So this is the cinguloopercular network right here. So this is the network, amongst other things, is your error checking network. In other words, this is the one when you do something, this is the internal check that says, well, did I do it right or did I make a mistake? Okay? So this is the network in a healthy older adult. This is the network in a healthy older adult with Parkinson's disease. So both of them are cognitively intact. Their networks look the same. Here's a person who has MCI due to Alzheimer's disease. Here's a person who has MCI due to Parkinson's disease. And you can see that these networks are quite disrupted, but they're quite disrupted in entirely different ways. So the darkest is really looking at the one-to-one correlation on that network. And then what you're looking is that the correlation and anti-correlation of different networks to that network, right? And so what you're looking at is this is what an intact network looks like. This is what a disrupted network looks like. And so, again, this is a blown-up picture of this little piece of the map right here. So what you can do is you can start to look at changes across different networks simultaneously and try to explain potentially why someone's behavior is the biological basis of this. So here's a different map. This is looking at the visual network. So this is someone who is cognitively normal. This is someone who has Parkinson's disease, and this is someone who has Parkinson's disease dementia. And so what you see is that if you're looking at the visual network here, you can see that there starts to pick up other anti-correlation sites for Parkinson's disease, which spreads dramatically when they become more cognitively impaired. Right? So we're able to really start to look at the biological basis of a lot of these behaviors as well. All right. So to summarize, older adults generally are quite willing to be screened and discuss memory issues, although not necessarily with their doctor. So we need to figure out how to do this, and part of the reason is they're not actually where the doctor can assess them. Okay? They think they have to go to a specialist. They don't know that their primary care doctor could actually potentially manage these problems. There are tremendous knowledge deficits and belief system issues regarding how PCPs approach older adults and how they incorporate new knowledge into their medical practice. So recent graduates are much more likely to incorporate things, whereas experienced practitioners are much more reluctant to adopt new practices. Physician behaviors really can be explained two different ways. So we can look at consumer-driven behaviors. That is, a patient or a family complains about something, they'll do it if they perceive that their other colleagues are doing it. If it's a guideline, they're going to do it if they think there's a benefit to doing and following that guideline. Combining a brief informant and performance instrument really increases our ability to pick up even the subtlest of cognitive change. Both patients and physicians are much more likely to accept the concept of dementia screening if it's put in the larger, broader context of healthy body, healthy mind. As knowledge is probably the biggest prerequisite of any behavioral change, it's clear that any intervention to be effective, we have to somehow raise awareness of the disease and the consequences of disease. So these findings really allow us then to start to develop very novel programs on a nationwide basis to have early detection of disease and get people into both the medical system and potentially into research participation. And I think it's really important to have us understand the context of the conversations that patients have with their physicians. So, as a final thought, so what we've done so far, I think I've given you sort of an overview of about 10 years worth of work in like 50 minutes, is we developed and validated dementia screening tools that are culturally and linguistically sensitive to the earliest forms of cognitive impairment. We really laid the groundwork for understanding what both the patient and the physician thinks about the disease, their attitudes, their belief systems, and their behaviors. We developed a platform for incorporating this into the idea of an annual wellness visit type of platform. And we've demonstrated the broad applicability of these by doing what we showed we could do in a public health